So how we have gone for the management of trauma. Everything starts with ABC when we are in emergency. And by doing A, B, C, D, E sequence, we can identify majorly all the life-threatening conditions, starting with airway. Basically, we have to adhere with A, B, C, D, E. Every patient reaching to us, we have to initiate our A, B, C, D, E. Then start with airway. When we start with airway, we does not singly include the airway. In trauma patient, we have to stabilize the cervical spine motion as well. So airway maintenance with restriction of cervical spine motion. B stands for breathing and ventilation. C is with circulation along with the control of hemorrhage that we have to take care in circulation part. Disability is basically assess the neurological status of the patient and pupillary reactions. Exposure is basically when you expose the patient, you see any long-borne injuries, and environmental conditions like hypothermia if patient is having. His participants are able to see the presentations. Hello everyone, can you see the presentations?
Just a second. Yes.
Yeah. Okay. So in airway maintenance with cervical restrictions, which we take care is basically we have to make a target for oxygenation, that is more than 94% of oxygen. If patient is not able to maintain this much of oxygen, so we can start with the supportive oxygen by non-rebreathing mask, high oxygen flow. Then if there is any secretion in the mouth, any vomitus, any blood secretions, then we have to go for suctioning. Then there is head tilt, chin lift that we can do. But in trauma patient, we have to be very careful regarding this head tilt, chin lift. So whenever there is a trauma patient, we prefer jaw thrust rather than head tilt, chin lift. Because when we do head tilt, chin lift, there we do a spine movement. So we have to restrict spine movement in trauma patients. So preferably jaw thrust is indicated. Further on, if by doing all these maneuver, we are still not able to maintain the saturation of more than 94%, we can use the airway adjuncts as well, which we have is NPA, that is a nasopharyngeal airway, and OPA, that is an oropharyngeal airway. But there are some contraindications for them also. If there is any facial trauma, we expect any nasal bone fractures or basal skull fractures, we are not going to use nasopharyngeal airway. But nasopharyngeal airway is having one indication that even in conscious patients, we can use it. Rather than OPA cannot be used in any conscious patient which is having his gag reflex intact. We cannot use it because it can induce the vomiting in patients by inducing the vagus stimulus. Now OPA, OPA is just having one contraindication that you cannot use in any conscious patient. Other than that, you can use it, and by doing putting airway adjuncts, what we really want to achieve is that we will protect the backflow of tongue, which will not obstruct the trachea. So by doing that, we can increase the saturation of the patient. Now, if all the maneuvers get failed, so we can switch to endotracheal intubation, which is basically require expertise. And if we are not able to do it, then we can use simple laryngeal mask airway, which is very easy to introduce and does not require much expertise in this. Now, if there is a situation that we are not able to go ahead, there's a lot of facial trauma, you cannot see anything inside, you are not able to go for laryngeal mask, this LMA insertion, endotracheal intubation, then we can go for surgical airway as well. And in surgical airway, cricothyroidotomy is we usually do in a state where we cannot ventilate the patient, where we cannot tube the patient, In that scenario, we can go for cricothyroidotomy followed by tracheostomy. Can we change the slide?
Doctor, is the same slide you want me to keep, or
yeah,
you want to change?
Yeah, thank you. That's it. Yeah. So as we have said, the cervical collar application is very important in trauma patients. We have to see determined need for the immobilization of the collar, cervical basically. Control movements of the cervical spine by putting the patient in a manual inline stabilization through holding the hand from the head side, spine from the head side. Basically, we can put our hands on the spine, the trapezius side, and we can hold it from the spine of scapula. By helping from these two hands, we can support the ear side. By this, we can even lift in a manual inline stabilization fashion. So make sure that the patient's head is in neutral position if required, or if there is no contraindication. When you can see there is obvious deformity on the neck, so definitely you don't want to align, make it in an align and cause any further injury to spine. And there's one more important thing, that you have to measure the size of the collar very appropriately, so the patient's neck is not congested or it is too loose. And we even if you put a collar on the neck, the patient is able to move it. So you have to make sure that the size of the collar is appropriate. So as there is any severe head injury patients who has altered sensorium, or whose GCS is 8 or less than 8, requires a definitive airway. So now uncuffed tubes are not preferred. So whenever you're going for an intubation, cuffed tubes are the preferred one, and which can be secured. Okay. So any person who's having altered sensorium with a GCS of less than 8 or 8 should get intubated. So establish a definitive airway if there is any doubt about the patient ability to maintain airway integrity. Most of the time we think the patient might have alcohol induced and he will get better after a time if we'll give him some time. So whenever there is a GCS of less than 8, either whatever the reason is, do not wait for that. Might be it will lead up into complications only. It will hamper the cerebral perfusion of the patient later on. It's better to tube, and then we will take care of the things. Whenever you are in a dilemma that you need to transfer a patient whose GCS is around 9, 8, 10 also, and you think that patient is having head injury, better to tube it in an early phase rather than shifting and then getting intubated in some other places. Yeah. Now, as we have completed the breathing part, now once breathing is controlled, then we can switch to, once the airway is controlled, then we can go for breathing assessment. Now, airway patency alone does not ensure that the ventilation is adequate. Adequate ventilation, when we say, then there is exchange of gases is there. Okay, so adequate gas exchange is required to maximize oxygenation and carbon dioxide elimination. It is very important that we have sufficient amount of oxygen and carbon dioxide as well. If the patient will retain carbon dioxide, so again it will hamper the cerebral perfusion. Now, ventilation requires adequate function of the lungs, chest wall and diaphragm. If there is any injury to lung, if there is any injury to chest wall, there is any rib fractures, flail chest is there, any diaphragm injury is there, so that will definitely hamper your ventilation. So starting with the inspection, what we're going to assess in patients, we can see the jugular vein, venous distension, position of the trachea and chest wall movements that we can see. We can expose the patient neck and chest to see the movement any obvious injury that has been appreciated on the chest and neck, by which we can see that patient is having injury, and we can further on take care of the ventilation part. Now on auscultation part, we have to make sure that patient's lungs is having equal air entry. If there is any obstruction, is there any reduction, if there is any additional sounds appreciated, that also indicates that there is injury to the lungs. Now on percussion, it is very difficult to do percussion in noisy environment. As in trauma patients, we always get noisier environment around. So whenever it is feasible, go ahead for the percussion as well. Look for the resonance of the chest. Now coming with that, injuries that significantly impair ventilation in short term, which are tension pneumothorax, massive hemothorax, there's open pneumothorax, and tracheal or bronchial injuries. If we have injury like these, they can impair the ventilation very quickly. Now, simple pneumothorax. If we get a simple pneumothorax, it can be converted into a pneumothorax. Basically, when we intubate patient, after seeing that the air entry is not there, let's patient saturation is low, patient GCS is low, let's intubate the patient. Okay, we have just seen the airway, we have not seen the breathing part. So what happened when you tube the patient, there is a positive pressure ventilator that you provide to patient. By doing that, you are increasing the pressure inside. So by doing that, you are increasing the simple tension pneumothorax get converted. So simple pneumothorax get converted into tension pneumothorax. Before going ahead for ventilation, before going ahead for intubation, what you can do, you can go for chest drainage. So you will not hamper this situation. Yeah. So later on, now we will come on circulation part. So basically it is very important that you rapidly and accurately assess the injury of the patient. Okay. By seeing the hemodynamic status of the patient. So the elements of clinical observations that yield important information within seconds are, there are three elements which can tell you the patient's hemodynamic status is not good. The patient condition is not good, basically. The level of consciousness. What happened, how it deteriorates, the circulatory blood volume, when it got reduced, it hampers the cerebral perfusion. Okay, so your perfusion got reduced, by which the level of consciousness also reduced. By looking at the skin perfusion, by seeing capillary refilling time, if it is more than 3 seconds, if there is Asian skin, pale extremities, and there is cyanosis on the skin, then you can appreciate that the skin perfusion is low. Now coming on a pulse, we can see that there is rapid and 3D pulse, which will be there if there is blood volume reduced. So what we have to do as quick as possible, we have to assess from where the bleeding is happening. Now the bleeding can be internal as well and external as well. So there are, I would say, there are major areas where there is internal bleeding that we usually cannot see externally, but can assess by these examinations. Just chest is a major component where you can have internal trauma. Abdomen, retroperitoneum areas where you can have, pelvis is there, long bones like your femur, where you can have major bleeding and which you cannot appreciate externally. Now, if there is any internal injury, like you have pelvic trauma suspicious, so what you can do, you can just apply a pelvic binder. If you have chest trauma, chest decompression can be done. If there is any long bone fracture, so we can go ahead and put, if externally we can see, we can just apply direct pressure over the wound. And if there is long bone fractures, like there is a closed femur fracture, so we can apply the splint as well to immobilize that part, so we can reduce the bleeding as well. So if there is external bleeding, what we can do, either if there is any arterial bleed which we are seeing, majorly flowing blood, so we can apply a tourniquet or just a few centimeters above to the wound. So what we can do, we can apply either tourniquet, but not more than 30 minutes. It should not be applied. And we can apply direct pressure over the wound. So by seeing either it is internal bleeding or external bleeding, it is very important to replace the intravascular volume. So for doing that, what we can do, we can take 2 large IV bore cannulas, preferably anticubital lines. 16 gauze is preferable. We can administer fluid, blood, and plasma products. Now, aggressive, initially in old ATLS guidelines, there was that we can give fluid up to 1.5 liter to 2 liters. But now, as per the 10th ATLS guideline, it is restricted to 1 liter, because aggressive and continued volume resuscitation is not a substitute for definitive control of hemorrhage. Now, on hemorrhage, what we are doing, we are losing blood. So in these patients, we are early at a stage of coagulopathy. The patient is already at a risk of coagulopathy. If we are going to transfuse more and more fluids only, then patient might land up into DIC later on, and the critical condition patient will just hamper in this situation. So initially, when we start with giving fluids, a bolus of 1 liter isotonic saline is preferred. If the patient is not responsive, then we should switch to blood and blood products. We can start with the massive transfusion protocols, which includes your PRBCs, your platelets, and fresh frozen plasma. Now, as I have already told you, that severely injured patients are at a risk of coagulopathy. So in these patients, it is preferred to introduce tranexamic acid. We can give tranexamic acid IV bolus initially within 3 to 4 hours of the incident, followed by an infusion for 8 hours. So initial bolus dose of tranexamic acid can be around 1 gram. Okay, and further on we can convert it into infusion.